Welcome. Just informing members to switch off all electronic devices, with the exception of the committee tablet devices. They will obviously interfere with recording equipment. I have one apology from Dahi Mackay. Any other apologies? Okay.
Oh, sorry, Chair Tom Buchanan.
Okay, thank you. Just item 2 is an additional agenda item today. Is briefing by the Permanent Secretary on the current position on key issues within the health service. Just want to advise members that the Permanent Secretary, Mr Richard Pengelly, is here today to discuss the current position on the key issues. There have been no papers provided, so you're welcome. Thank you for attending, Richard.
Thanks, Chair.
I'm going to ask if you want to make a few opening comments.
I hadn't planned to, Chair. I thought I just wanted to go on to questions, if that suits you, okay?
It may be useful to have a few comments from yourself in opening.
Well, I mean, maybe your guidance, Chair, about, because I'm here in the back of a phone call that you wanted me to come along, so I don't have a list of specific issues you want to talk about, and that's why there's no paper. I thought I just wanted to move into questions.
Okay, we'll lead it through questions then, Richard. Thank you, and thank you for agreeing to come along to this today. Obviously, hugely important position we find ourselves in. Can I just ask, maybe, quite frankly, to begin with, is it currently business as usual?
Well, I mean, in the absence of a very precise definition of business as usual, it's as close to business as usual. I mean, none of us would pretend that we're in a perfect situation, but in terms of operational issues, it absolutely is business as usual. The business of the health and social care sector continues. Patients continue to be seen. The key issue with the position with the Minister, and the Minister's particular involvement clearly would be on the high-level strategic issues. But in the period since the 10th of September and the first resignation, I have had a good amount of time with the Minister every week following the renomination. And certainly in the course of those discussions, he has cleared some key issues, and certainly we've had a longer discussion about the general direction of travel and some of the strategic issues, and he continues to give us that guidance. So whilst it's not perfect, I certainly don't see anything in terms of that strategic piece where there's a fundamental flaw in it.
So if it's as close to business as usual, what is not happening?
Well, I would, the biggest manifestation of it probably, I mean, if you think about the two key roles of the Minister, there's the strategic direction role. What's not happening there is to the extent that there is absolute unfettered access, where if an issue comes up, we can have a conversation. Now, that doesn't happen. That's not the norm. It will happen from time to time. I can honestly say that over the last 3 weeks, there hasn't been an issue on my desk of such strategic importance that I thought I really need to speak to a Minister about this, and I've been unable to do that. We've had some very good strategic discussions. I think where probably the bigger gap is, and as important as it is, I would say it's not anything like as significant as the strategic issue. The duties that the Minister would perform on a very regular basis in terms of that outward facing, but the engagement with the community, attending functions, attending events, meeting delegations of interest groups. And I don't want to underplay, Chair, the importance of that engagement and dialogue. But if we're talking about a period where that doesn't happen for a couple of weeks, again, I don't think it's on the sort of seismic scale.
But you're saying, obviously, it's as close to business as usual, but it's not perfect, and you've alluded to strategic decision-making. So if there is a strategic decision to be made, are you in charge? Can you make that decision?
No, issues that need ministerial decision will always need ministerial decision.
So as it stands currently, if there's a key strategic piece, of which, in my view, there are many, that need implementation, you can't do that?
Well, it might be helpful maybe in the course of the session to give some example of the sorts of issues you have in mind. What I would say is there hasn't been an issue over the past number of weeks where we have had to absolutely slam the brakes on what we're doing because something needs a ministerial decision and we haven't been able to get it. I mean, ultimately, any department operates at the direction of a minister. So the position that the Minister put in place before resignation sets our policy and strategic direction. I can take any and all decisions within that environment. What I cannot do, for example, if a decision lands on my desk, is to say, this isn't an issue that a Minister has given any consideration to, but my view is that the Minister would pick X or Y. I can't do that.
But if a Minister has made recommendations, or there are recommendations on his desk, as it stands currently, you can't implement those. You can't write the cheque.
Sorry, if the Minister has agreed recommendations? Yeah, if the Minister has agreed recommendations, we can carry on with the implementation of that.
Well, if there are recommendations that need to be, I'm thinking, for example, commissioning.
Yeah.
There is a review and commissioning.
But the review of commissioning, there isn't a decision on the Minister's desk. The dialogue that we've had, I mean, we've captured a huge amount of evidence in that. We've engaged with colleagues across the sector. We're collating evidence, trying to formulate where we end up on that. And as we do that, we have had regular discussions with the Minister, both pre and post the 10th of September. So that issue...
But there was a report done and a review done, and there was a report due for August.
Yes, and but that hasn't been completed, but not...
You can't do that. You can't action that in the absence of the Minister.
No, but the report hasn't thus far been absolutely concluded and put. There isn't a report sitting on a Minister's desk awaiting for sign-off by a Minister. We've been continuing to work on that because I think the aspiration about the date that you talked about, I think we had to engage much deeper and much wider than we first thought in terms of colleagues across the system. So we have had a considerable amount of ministerial input to that. I would say we're very close to the finishing line in that, but you know, where I sit right here and now, I haven't put a final set of recommendations to the Minister for sign-off.
Do you consider yourself, in this scenario that we find ourselves in charge? Can you progress and make decisions and write cheques?
To a considerable extent, yes, but what I cannot do is take the place of a Minister and take decisions that are the preserve of Ministers. But decisions that have already been taken by Ministers, I can implement them, I can authorise payment for the implementation of those, and we can progress those.
Do you think that this in-out relationship that we have currently is impacting across the service?
Chair, my assessment, as I said earlier, is it's not a perfect situation. I don't believe it is impacting across the service in operational terms, because the Minister does not get involved in operational issues.
But it is impacting on strategic terms.
I think we need to bear in mind, at the moment we're talking about a situation that arose on the 10th of September. So in early August, a few number of weeks later, the strategic agenda for us is one that will map out the direction of travel for the health and social care sector for the next 5, 10, 15 years. And that will take a fair bit of time to implement. So I absolutely do not believe it has had a fundamental impact or any significant, is it causing any significant delay with that piece of work.
Is the system in crisis?
The system, again, I don't want to get hung up in definitions. The system is in extreme difficulty, and we can talk about the reasons for that. Whether that's crisis, you would characterise that as crisis. I mean, certainly for someone who is sitting on a waiting list facing the prospect of a year more's wait, I absolutely think that individual would call this a crisis situation. But we need to bear in mind that in terms of the normal run of health and social care, there are 30,000 outpatient appointments conducted every week, over 230,000 GP patient consultations. So there is a huge amount of activity that continues to a very high standard delivered by hugely committed and professional staff. So,
but you see, I'm not sure, Richard, where extreme difficulty ends and crisis starts.
Neither am I, Chair. That's why I'm struggling to, just completely agree that it's in crisis.
Well, in your opinion, are there pieces where potentially, if this continues, in your view, that we would see public concern and potential crisis around the delivery of health if this continues? And what are those?
Well, I'm not sure, Chair, there's any merit in me trying to get into the space about what differentiates a crisis from an extreme difficulty. There's no doubt there is a large measure of public concern and concern in the Assembly from elected representatives, and rightly so. By any measure, it is at minimum an exceptionally difficult and challenging position we face. But, I'm not, to be frank, my job and responsibility is to try and deal with that rather than spend too much time debating what label we attach to it.
But is your job and responsibility not to forecast and plan as well?
I don't think, Chair, that anyone in Northern Ireland should be surprised about the position we're in. It has been, it was clarified by the previous minister, I think, in this committee last October. He was very clear about the direction of travel we were in with the funding envelope we had for this year. So it's not that this has snuck up on us in some way.
But I'll ask again then, in your opinion, can you foresee any crisis which could develop if this situation continues?
Well, I can see a situation developing where the waiting times will continue to deteriorate. But, and I suspect as we'll come on to, the way, in the short term, the only way we will address that issue is through securing additional funding.
And, okay, so what are you then as Permanent Secretary, as the person who is in charge, albeit loosely, what are you doing to mitigate that? What actions? Is there an action plan? Is there a developing protocol around how we tackle that? If you're flagging this up today
Yes,
as potentially a deteriorating situation.
we have commissioned from the Health and Social Care Board, who remain the commissioners of the delivery of services, a medium to long term plan for addressing the problem of elective care. And that's looking at how we can, over a period of years, actually get the position back in.
But where is the plan, Richard?
Well,
The commissioning plan isn't even agreed.
the commissioning plan, as far as the board is concerned, the commissioning plan is as close to being agreed. The Minister wrote to the Chair, I wrote to the Chief Executive of the board some weeks ago saying the Minister was largely content with the plan. There was a couple of minor caveats where we had asked the board to come back to us with some assurances. The position, the assurance they received is absolutely adequate for the board to get on with implementation of the plan, and we await. I think I saw last night in my inbox the Chief Executive.
With respect, as close to being agreed isn't sufficient enough whenever that is going to be the format for the delivery of services, which would include, I would assume, a key responsibility in and around waiting times. So as close to being agreed doesn't wash, I suggest.
I accept that, Chair, but your proposition is then that the Minister should agree something he's not happy with. The commissioning plan was put to the Minister for approval. There was a couple of additional assurances he wanted from the board as implementers of the plan. He wrote to the board a number of weeks ago asking for those assurances. We await the board's detailed response.
So can you progress
the Minister indicated, Chair, that he was broadly content with the plan. That was a sufficient steer for the board to get on with the plan.
So if the board comes back and addresses those issues, can you implement?
Absolutely.
You can take this piece forward.
Absolutely.
Okay. In relation to the two pieces of legislation, the Health Miscellaneous Bill and the Health and Social Care Regulations. Health Miscellaneous Bill, is it going to be introduced?
It will be introduced. At this stage, I just can't say precisely when it will be introduced. I mean,
Is it at risk?
I think, from memory, and I'd need to confirm this absolutely, Chair, but my memory is that we would have, in terms of the normal timeline, as long as it's introduced before the end of this month, it won't be in risk in terms of timing issues.
The end of October?
Yeah.
That it would still be due process through proper scrutiny?
I'll need just to double check that for you, Chair, but that, from recollection, that's.
So you don't think there's any risk?
Well, of course there's a risk. For as long as it remains not introduced, I can't say there is no risk. But at the moment, I think your question was, is it likely to fall because of time? As long as it's introduced before the end of October, there is time for it to progress satisfactorily through the Assembly.
And is that the same for the Health and Social Care Bill?
Off the top of my head, Chair, I'm sorry.
Can we have that clarified?
Yeah, oh, absolutely, Chair.
And one more point that I would raise, and I know the Deputy Chair wants to come in because he has another meeting to go to. This document that was formal guidance to the department around changing the culture of care from the Older Persons Commissioner.
Mm-hmm.
Where is that currently at?
I'll need, as I say, Chair, without advance notice of the specifics of these, I'll certainly check the detail of that out and get back to you. But
you see, I find that really concerning.
Well, Chair, I find it concerning that an assumption that I should have a photographic recall of every single issue that's live in the department.
But this was formal guidance that was given to the department in November 2014.
I think it's of fundamental importance that I make sure answers I give the committee are accurate. And what I want to do is come back to you with an accurate articulation of our position in that.
And what I'm saying back to you, Richard, is that this report on time out of number referenced significant failings in the level of care provided, with advice, formal advice to the Minister, formal advice, 4 recommendations, and alluded to, these proposals require consideration and action by the Health Minister, and that was in November. And very, very concerningly, flagged up those significant failings on how our older people and vulnerable people are being cared for. And you're saying you can't respond today. This was formal guidance to a minister.
Well, Chair, I can only apologise, but I cannot carry the detail of every single issue that is live in the department in my head to be produced. I'm sorry.
But you're in charge.
But being in charge,
means being in charge.
No, being in charge means leading other people. It means having good people around you. It means delegating, giving them authority and responsibility to take pieces of work forward and at various times. I can't do every single piece of work in the department myself.
But I find it irregular, Richard, that you come here to committee today to discuss the current situation in relation to health. And what we want to know here today is who's in charge, who's taking the key pieces of work forward. That's a critical piece of work. And it's a critical piece of work that highlighted major, major failings in our system.
But Chair, with respect, the reason I'm here today is because you phoned me at the end of last week and said, can you come along and talk about the Minister not being there?
Exactly.
So if you're now extending it to talk about the specifics of other issues, I would like a little indulgence that maybe I can't be
Richard, there was a number of issues last week. And yes, of course, we're asking you along today to address the fact that the Minister's not there, because that is leaving a gap that is well identified across our sector. So, of course, we will flag up the issues that are currently on the Minister's desk that can be actioned, and this is one of them. So I would have assumed, as Permanent Secretary, that you would turn up today equipped with the details around that.
I'm sorry, Chair, I have turned up today to talk about the issue that you told me you wanted to talk about.
Yes, which
and we have a
impacts on this.
Clear mechanism where you highlight issues for agenda, we produce papers, we come along and we provide as much information as we can. But if we get in a situation where we're invited along to talk about one thing and very specific points about other issues are dropped in, it's unfortunate, but it is difficult to respond to them with the level of accuracy that the committee deserves.
But you're in charge, Richard, and I would suggest to you again, because there are a number of pieces there, and I know there's a number of members looking to come in, but this is a key piece. I mean, this was not just a report that was produced by a sectoral organisation. This was the Commissioner for Older People who gave formal guidance to the Minister in November 2014. And now we have a situation where we don't have a Minister and a Permanent Secretary is in front of us saying, I don't know. I find it irregular.
Well, I accept that it's a key piece, Chair, but I would hope that you would equally accept that it is not the only key piece of work in the department.
No, there's quite a few
strands of work, and I'm trying to lead and keep momentum going on a whole range of issues. The consequence of that is I need to rely on the very, very capable and professional people around me to take forward bits and pieces of that. And that means that at any given point in time, if I am asked suddenly a specific question about a piece of work, it may be the case that I can't answer with graphic detail. I'm sorry, but that's what it is.
But you can't even allude to how this has been progressed.
Because I think the committee wants a detailed and specific answer, and I will provide that.
The committee wants to get a sense of what happened to it.
And we will provide that to the committee.
But you don't know, you can't answer that.
We will provide it to the committee.
Okay, look, I'm going to bring the Deputy Chair in because I know that he has to leave to go to another meeting.
Yeah,
Alec.
thank you, Chair. Richard, in your opinion, the day-to-day running of the health service hasn't been affected by the Minister's?
No, as I said to the Chair, I would define the day-to-day issues of the health service, that activity that happens in GP practices, in hospitals, in community services. The Minister has no day-to-day role in that. That continues under the guidance of the clinicians who lead that piece of work and the very committed staff.
And there's been no major issues during this period that you've not been able to deal with, or
there have been the big issues that we're dealing with, the things like Donaldson and the review of commissioning. I've had an opportunity on a weekly basis for the Minister to give me his strategic direction on that, so that they haven't suffered. There's no decisions sitting on my desk that are burning at the edges awaiting.
So you're in regular contact with the Health Minister every week, basically?
Every week after renomination appointment.
Okay, thank you. In terms of the waiting lists, obviously they're getting worse, and that's down to a lack of money, basically. Wouldn't that be pretty much the case?
There are a number of it. I would say that the financial issue is the single most significant issue, but just to be complete, the other big issue is demand. It's interesting that if you look at, sometimes the public judge the performance of the health service by reference to the metric of waiting times. And I can understand why that happens, but the problem is when you factor in rising demand, and there's increasing demand both in numbers and in the level of acuity of patients that come forward, that means that, as we have at the moment, where in activity terms, last month there was more activity in the health service than there was in the previous period last year, so we are improving performance, but that increase in performance isn't as sharp as the increase in demand.
Yeah.
So at one level I would say performance is improving. It's not improving quickly enough to keep up with demand. And factor that in, factor the pressures in unscheduled care, which obviously have an impact on elective care. But the single biggest issue is the availability of funding. And particularly in previous years, when you look at the use we've made of the independent sector as a safety valve, the funding for that has been drastically reduced this year, so that remains a big issue.
So basically, using the independent sector, you would have been quite reliant on sort of like monitoring rounds to boost that activity within the independent sector?
We would have been reliant to boost it, but even within our baseline, we would have had a measure of funding. But this year, with in the last budget, we were very grateful to get it from the executive. We received support in real terms. The problem is demand has grown greater than real terms, so we struggle to keep up. Even our baseline funding has been insufficient. So I think the point I would make is it's not just that we're reliant on monitoring, we're becoming ever more reliant on a monitoring system to receive funds to keep up activity.
Yeah. So it's not been helpful to you in terms of getting money down to the department because of the arguments due to welfare and the fact that we're getting fined every month. I think is it 10 million. So that's money that could have gone into the health service that would have helped you in your waiting lists.
Well, I hope you appreciate it.
Yeah.
I don't want to stray into the politics. I mean, from my perspective, we made a significant bid in June monitoring, which would have helped us alleviate some of these issues. For issues that are out with my area of responsibility, there was no June monitoring round. We didn't receive any allocation, so that, from my perspective, that is a key cause of our difficulties.
So welfare getting resolved is probably helpful to you, the department? Well,
I would say that the executive allocating additional funds to us would be very helpful from my perspective. What takes place in the political echelon to facilitate that is not an issue that I...
Okay, thank you, Chair.
Thank you, Alex. Kieran?
Thank you, Chair. I must say I'm very disappointed in your responses so far. First of all, coming in, not a paper in front of you to explain, give us an indication of things, and you've been going on about availability of funding, baseline funding insufficient, etc., etc. I have a document in front of me here, and it says our latest assessment is that the department will live within its available budget, right? And then you go on to say that achieving financial balance will have service implications for patients and clients. In other words, you're saying what has been said in the Assembly week after week. Last week it was waiting lists, cancer support, and this week it was autism. And yet you say that you're going to be able to live within your budget. What is it? And why is it that all of these things, you mentioned also that the health service was in extreme difficulty. Some people have used a health service in a crisis. I would say that the health service is in a shambles. And from what I'm hearing from you this morning, we are going to continue with that shambles, whether there's a minister there or whether there's not. Can you give me some idea, and again, can I refer to the last time your officials came here, I don't know whether you were with us or not, you were looking for 98 million from the June monitoring round, of which you haven't got. You haven't got one penny.
89 million?
89, sorry about that, yeah. Of 45 million of that was to try and overcome the waiting list. You haven't got that. So is that why we are go on a downward spiral in relation to my constituency who are waiting desperately to see a consultant or to see whoever it is to get them out of pain and suffering? I mean, Chair, I could go on in relation to, well, the waiting list. The cancer support is another. That is, you know as well as I do that it's unbelievable that people have to wait to see what the next stage in the cancer treatment. Autism, which we spoke about yesterday, I have a list of questions, and I'm going to. We wouldn't have time to discuss them this morning, but I'll ask you to take them with you. I mean, the Autism Act went through this House in 2011, and there is a lot of disappointment that contained in that Act. A lot of stuff has not been implemented. For instance, funding for the awareness campaign in that Act, that never has happened. There's also the... Could you comment on how things are measured? Also, can you confirm whether claimed progress will be independently scrutinised, validated or self-reported and regulated? This is all to do with the Autism Act, which a lot of stuff has not been implemented. Would you agree that public confidence would be best served if the departments did not police themselves, for instance? I'll give you, Mr Pengelly, that list, particularly from autism, and I would expect that you can answer the committee on that. But, you know, can you see where we as public representatives are, and also the Donaldson report? This committee asked for an update on the report of the Donaldson. We got a letter back from the department saying that, oh no, we can't give you that. Your department cannot give this committee a report on how the 99 recommendations are being taken forward. If that's
Sorry, are you talking about transforming your care?
Yes,
Donaldson?
absolutely, yes.
Sorry, Donaldson?
The Donaldson report and the back of it, transforming your care. You spoke about it there earlier.
Yeah.
And you couldn't even give us an update on how those recommendations were being brought forward. That proves my point that the health service is not in crisis, they're in shambles.
Okay.
Can you give us any explanation of where we're going, simply because you didn't get that £45 million for existing service pressures, elective care diagnostics, transforming care, etc.?
Well,
and you sit there and you say that we're in extreme difficulties. As I say, I think we're in shambles.
I'll try and pick up on a number of issues you've raised on. Firstly, in the point, I think the paper's been prepared for the session duties coming to this afternoon, the financial position. We're on course to break even. We're on course to break even because that is a fundamental responsibility on the department to live within the budget that has been set by the executive and approved by the Assembly. I don't think we've any other choice but to do that. The consequences of living within budget are that we can't deliver as wide and as broad a range of services as we would want to. And I think the point that has been flagged up, it certainly would have been flagged up at the time of the June monitoring round when the £89 million bid was submitted, that the consequences of not getting that funding will mean reduced levels of elective care activity. And that's
waiting list will continue.
Yes, but that is a consequence, because the simple reality is, and forgive me for stating the obvious, we can't increase activity unless we have the funds to pay for it. Elective activity is not cheap. It's either done through extended opening and use of overtime in our own trust facilities or use of the independent sector. So if we don't have the money to pay for that, if we bid to the executive for the money and that's not forthcoming, that activity can't happen. The consequence of that is that our levels of activity cannot keep pace with demand, and hence waiting times will grow. But again, that's a point that has been flagged up on many occasions before today. In terms of, you touched on autism, and I'll certainly take your questions and we'll come back with comprehensive answers. The official position on autism is that between 2010 and last year, the number of referrals increased from 1,500 to 2,900. And so we don't have the capacity in the system to keep pace with that. To create the additional capacity to actually deal with the diagnosis and the subsequent treatment would cost around £2.5 million a year. So that again is a financial issue we'll press. In parallel with that, the response, we've actually asked the clinicians to undertake a peer-led review to look at the clinical pathways and to look at ways we can reshape the service within current resources to try and get through those referrals more quickly. And at the same time, I think it's important to point out that we talk very much there about the clinical pathway and the diagnosis through treatment. At a very early stage in the referral process, there are a number of other services and support services available for the families affected, which would certainly signpost, like educational psychologists, speech and language therapists. So it's not that the children and young people affected are left in isolation. There is some support, absolutely not the level of support any of us would want to give to them. But again, and at the risk of repeating myself, unless and until we get the additional resources to put in place, the additional clinical support to deal with those, numbers have virtually doubled in that 4-year period. So, that's going to be a difficulty. We have over 800 people waiting more than 13 weeks. So
you're admitting that there has been a breach of the legislation, the Act, that you have not. You did say that there was an increase of, I think it was some 60% of youngsters with autism. There has not been 60% increase in funding to cater for that. So therefore there's a breach on the Act that was passed in 2011. Which is totally unacceptable.
Well, but if we don't have the funding, I mean, there's a risk that if we take each of these issues in isolation, we lose the bigger picture. The reality is, within a fixed budget, within which we have an absolute obligation to live, in any one area where we spend more money, we spend less money in another area. And everywhere we look in the health services are fundamentally important, particularly from the perspective of the patient or client who receives that service. So there are very, very few easy choices here.
Okay, Chair, that'll keep.
Joanne, next.
Thanks, Chair. Richard, you will no doubt be aware of the motion which most of us took part in on Monday, in the Chamber on Monday, and in the absence of a minister to answer these crucial questions, I'd like to, on behalf of cancer sufferers, I'd like to focus my questions on cancer services. Sure. Of all the missed targets, the one which most concerned me was that only 27% of breast cancer sufferers in the Belfast Trust were seen within 14 days. So can you explain why this was, as the Northern Trust met the target with a similar number of patients?
Sure. If I look at the 14-day target, I'll try and briefly cover the 5 trusts. The 3 trusts, the Northern, the Southern and the Western, are pretty high level of compliance with the target. The overall Northern Ireland target currently is being dragged down, mostly by performance in the Belfast Trust and secondly by the South Eastern Trust. The big issue with the Belfast Trust has been the inability to secure the necessary staff resources, particularly at consultant level. The one ray of optimism in this is that, speaking to Belfast Trust as recently as last week, they have now secured the additional resource. The consequence of that had implications for the South Eastern Trust. South Eastern Trust poor performance was in a considerable measure due to the fact that, given the problems in Belfast, they had started taking patients from Belfast to treat because there was such difficulty. So that pulled the performance of the 2 trusts down. The Belfast Trust is now confident that by October they will be back to 100% compliance with the target.
Now, this
month.
This month.
They're confident that when we report the figures for October, they will be up to. They have the staff resource in place. They are also running additional evening clinics to try and catch up with the demand. So there's a clear recovery plan there. The big issue was securing that staff resource. I mean, that said, and it's good it's getting back to 100%. I mean, it's hugely regrettable that vulnerable patients were put in that position of us not complying with that target, and it's a fundamentally important target for us to comply with. And
it's simply shocking because I'm sure you're aware yesterday at the invite of the Minister, we attended the PHA, most of us attended, there was a PHA event to promote Be Cancer Aware and Be Breast Aware month. And so on the one end of the health service is encouraging women to come forward and to further breast checks for cancer, while on the other end they cannot cope with the pressure. So therefore, you know, it's brilliant more women are coming forward, and it certainly was very much on for that campaign. But if they don't get the treatment or don't get those urgent referrals, you know,
Absolutely.
you know, so it's patience, as you say, if it's one of the most treatable cancers, if it's caught early enough. And I'm pleased that you're readdressing that. I hope we're not in the same position that it's still not, you know, you say a consultant has been put in place, because it was so shocking.
It was. And
it was a total disgrace. You have to admit it was a total disgrace, those figures.
It's not acceptable to us that the performance is at that level. I mean, we can, and I'm not going to sit here and say it's due to issues outside our control, the service we're providing. The one point I would say is, and amongst this, and I only say this to be fair to my colleagues on the front line delivering this service, I think it's important also to reassure the public by saying that the recent European study showed that we have the best breast cancer survival rate in Northern Ireland, across the United Kingdom and Ireland.
If caught early and if they receive the treatment.
But as we stand today, we have the best survival. So I think that's an important point of reassurance. But that requires us
27% within 14 days.
But we have the best survival. I mean, I accept the point on the performance. The performance has improved, but I think it's important just to provide comfort to people and to recognise the effort that goes in.
What's the backlog then with, you say a consultant has now been appointed, what is the backlog then with the Belfast Trust? Because obviously there's so many women waiting for, you know.
I'm not sure. I know that I think in June, again, there's an issue about increasing demand. I think there was something like, from memory, about 1,300 patients seen in June.
Because of the campaigns that we all supported yesterday.
Well, I think the campaign, we would expect to see that spike in demand in the latter part of this month and in November.
Could you provide those figures then with
yes,
the backlog
just
as well?
In terms of the working of that campaign, the Trust is planning to put in place some evening clinics in anticipation of a spike in demand through the publicity of PHA.
Do you feel that women were coming to harm because of this situation, 27%?
Well, I can't. I mean, that's a clinical matter. I mean, the reality is the target is there for a very good reason. It's supported by clinicians. So, but you know, it goes out with my area of competence in terms of the clinical dimension to it. Okay.
The Chair touched on this earlier, and just for my own mind, and it's something that I'm asked constantly by constituents as well. Who today is ultimately accountable for our health service in Northern Ireland? Is it you? Is it Valerie Watt? Is it the Trusts, the absentee minister? Who is accountable for all of this?
Well, the minister is ultimately accountable. I mean, there's various, in terms of value for money issues and spending in the health service, I have a personal accountability to the Assembly for the value for money of spend within the health service. The Minister is accountable to the Assembly for the policy directions and the policy choices.
But he's an ultimate control.
He's an ultimate control, but in terms of just following that accountability thread, in practical purposes outside the Assembly chamber, the main vehicle of discharging that accountability from the policy perspective is undertaken through this committee. And the reality is the Chair...
You can see the frustrations around this committee, and the Chair tried to find out who on earth...
But the only point I would make is the committee's work continues and officials continue to come along every week, so it's not as if there is a complete vacuum.
But people continue to wait.
People continue to wait, but I say that's an issue of operation and finance.
But as we sit now today, who is in ultimate charge? But don't have
right
now,
the Minister.
Until he resigns.
Until he resigns again, yeah.
Well, I
is he in
can't
post
anticipate.
Is he in post today?
The Minister is in post at the moment, yes.
For how long?
I met with the Minister this morning before the committee and we talked through some strategic issues.
Would you accept that there's a gap of strategic leadership?
No, I wouldn't.
Not at all?
As I said, the situation is not perfect, but is there a gap? I don't believe that there's a gap because it is my role to provide a measure of strategic leadership. I am in post continually throughout this period, and I have a considerable period of time with the Minister on a weekly basis. Prior to the issue of resignations, the amount of time I would have spent with the Minister on strategic issues was not fundamentally different to the amount of time I currently spend with him on a weekly basis.
Can I have one final point, if I may, Chair? Finally, given this Assembly's unanimous passing of Monday's motion on cancer waiting times, have you read up on that motion? And we had a very good one, SDLP motion done yesterday on autism as well. I take it you've read up on those motions, have you?
I saw the generality of it, but I haven't read through every line of it.
read through to see the
Well,
concerns of
but-
individual MLAs then?
With respect, I can't, I mean, is the expectation that I read through the detail and I don't rely on...
This is the Northern Ireland
But-
Assembly, this is the
I
will.
accept this Assembly, but with respect, can I ask, is it unreasonable that with 65,000 colleagues in the health service, I have...
We're the
is
elected
some
representatives reflecting the views of our constituents
But if the question-
on 2 motions. Yes, Fairliffe.
Can I just come in on this
Sorry,
point?
I have to deal with this point. If I'm here and the issue has been raised about who is providing strategic leadership, what I'm getting today from a number of members is the requirement on me to continue to provide strategic leadership. Strategic leadership is strategic in nature, so we can't have it both ways, that I spend all my time in the trenches doing the operational detail and trying to do the
But
strategic.
we could expect you to have an overview, Richard,
And I do have
of
an
the
overview,
pieces
Chair.
that are pending,
2 important debates.
Yeah.
of the
Sorry.
pieces that are pending and decisions that would flow from it.
Can I get just?
Fergal, yes.
Sorry, thank you for letting me in, Chair and Joanne. Can I just concur? Would you understand that had the Minister been in charge, that he would have been at those motions yesterday and on Monday to answer every point? And is Mr McKelly making a different point in that sense then, that he in fact isn't aware of the detail and therefore there is a gap in the knowledge at the top of the health service?
Totally agree. The Minister should have been there for those motions. And our role as MLA, where they're reflecting the views on behalf of our constituents. Cancer waiting times and then autism, 2 vital motions. So I was going to ask you what has been done and what planning has been made after our motions. But if you aren't even aware of what we've said, you've only a scant view of the motions, you've no plan of action. Where's that then?
Well, I think with respect,
Does the work
I
of the
didn't
Assembly
say...
count for nothing then?
I
Is that
didn't-
totally disregard? Then does the work of the Health Committee
that's
count for
what he's
nothing?
saying.
No, it's not what I'm saying, Mr McKinney, please.
Sorry, the implication.
Well, you draw your own implication. What I have said, and I think what I've illustrated, is that we are working and trying to address the waiting times issue. We have a clear plan of action in terms of the operational issues to it. I think it's unfair to suggest that because there wasn't an immediate response to a very important Assembly debate in
Well, with
terms
no
of...
minister. With no minister. So,
Well, that's... I
in
mean,
the
that's
absence
an
of a
issue.
minister, surely you would have went through an overview, as the Chair said, of 2 vitally important motions. Surely,
But
you know,
what, the sense I'm trying to
how are
differentiate...
we going to get action from those motions
The
if
sense
you
I'm
didn't
trying
even...
to differentiate is, and I think it's helpful, and I think it's unfair if the committee doesn't recognise this, but that's the committee's choice. We need to differentiate between what any individual does and what the system does. The system is comprised of a lot of moving parts. I think if we're going to carry the strain and in any way seek to address the multitude of challenges we face, we need to allow each of those moving parts to address the bit relevant to it. Certainly, I am not suggesting, and forgive me if this hasn't been clear, that as a department we are not paying incredibly close attention to what the Assembly says in these matters. They are, of course, of fundamental importance, and we're looking at them as a department. But that simply does not mean that I personally do every single piece of work
There
in the
were 2
department.
motions, Ulster's motion and cancer waiting time, the SDLP motion on autism. We were there on behalf of our constituents, putting those concerns across, yet I was going to ask you what you're doing on behalf of it. Does that mean that our motions here count for nothing if you're not taking those concerns on board?
When you say what are you
Motions
doing...
were passed
when
with
you-
no minister, so he wasn't able to answer, so you're the
Yeah,
permanent
but
secretary.
when you say what are you doing, do you mean what am I personally doing or what are we as a system doing? Because I think it's more important what the system does.
Yeah, well-
and what
well,
the system does
But
is...
you're not even aware what was said on them.
Because it's currently being analysed and the component parts of it being drawn out for my attention. I cannot, I'm sorry, it's just physically impossible. I cannot be in every place
But
at every
Richard,
time
I
and
mean,
monitor every piece.
this isn't
Yeah.
isolated.
Totally.
Already this morning we've heard that we don't know in terms of the legislation. You think it's October. We've heard...
Sorry,
that you
Chair,
don't-
sorry, Chair, I think that's grossly unfair.
Well, I mean,
you asked me
yes, you said you were going to check the date,
very,
so you couldn't tell me the
you
accurate
asked me a
date.
very specific point of information. I've given you an answer. Chair, it would have been the easiest thing in the world on Thursday or Friday when we had the phone call. You could have given me a list of pieces of
Why
information.
would I
that you-
have to give you a list? You're in charge.
Because if you want complete
But
comprehensive...
you're the
Chair, do
permanent
you think
secretary.
I c-
You should have been coming here
Well, I'm-
with an overview of the gaps in the system
sorry, Chair, I
currently
am
and how they're being addressed.
I am incapable as I think any individual is, of carrying every scrap of information about every issue.
It's not
about
every
service
scrap,
in my head.
Richard. I mean, I think that's
Well, I disagree, Chair. I'm sorry.
disingenuous. It's not every scrap of information. We appreciate and respect the fact that there are professionals in the system who should be working with you and guiding you on this. But I would have expected today that you would have come here with at least an overview of where the gaps are and how they are being redressed. And, you know, it's not just
Chair,
about the two motions.
I've done that, Chair. I've talked you through some of the issues. I mean, is there a question about gaps that I haven't responded to?
I mean, every piece of information we've raised this morning, Richard.
Chair, now
Every piece.
Chair, use the word
The
disingenuous.
Chair-
I think that is unfair, Chair.
The
that every
care
piece of
provision, the
Chair, I
two
think it's
motions,
unfair to
the
say
waiting
every piece
times,
of
the
information.
commissioning plan.
Chair, I-
Point of order.
Sorry, George.
I think, quite honestly, I've listened very intently, and I think the official came to answer certain questions, not everything that you've put him on other members as well. He's done his best. At the minute, the official has done his best. I think that's absolutely ridiculous.
Well, I mean, that's your view and you're entitled to it.
It is my view.
I also just, I mean, think that you are the person that's in charge.
I do appreciate.
He is the person that's in charge, and we did expect today to address the current situation in relation to the delivery of health and social care. And that means there are key pieces that are sitting there, in my view, that could be actioned. We wanted to get a sense of your delivery around that.
Chair, I think I have sought to address that, but I mean, it's not impossible. It's not possible to distill the key pieces of health and social care into one paragraph. There are numerous. I mean, if we want to talk about waiting times, the only way you can accurately talk about waiting times is if you break it down into analysis at specialty level, because we can. There are different challenges for cancer treatment, for orthopaedics, for ENT. There's a whole range of issues. So we can't talk about that. I think I have sought to cover the points that you indicated to me you wanted to be addressed today. I apologise at your frustration that I can't answer questions that I wasn't have advised of or I couldn't anticipate. I have said I will come back to the committee very quickly with a comprehensive response. I'm genuinely not sure beyond that what I can do to help the committee.
But, you know, I'll just make this comment because I know there's a number of people and I know we're pushed for time. But, you know, this is not just this committee that are pointing up these issues. I mean, we've had a litany of sectors of, you know, just last week, Nigel Edwards saying people will die. You know, College of Nursing, College of GPs, trade unions, I could go on, individual members of society. So this isn't something that simply had to be flagged up by the committee to give you a list of what the issues were. We would have expected you, Richard, to come here with that overview and how they're being rectified.
And I think I have done that, Chair.
Well, I haven't heard that
the
today.
points you're frustrated with are specific points of detail you've sought to ask.
I haven't heard that today.
Just finally,
So I
Chair,
wanted
thank
to
you. We
finish on
brought the motions because we truly care about the health of the people we represent. Now you're saying you don't know the detail of them. We need a message to bring back. People are asking us what's the outcome of the motion that we brought in Cancer Times and the autism. No answers. With no minister to address, to reply, you have no answers whatsoever. You don't even know the detail of them. What message does that send out to the general public?
I think the message we send out to the general public is, as I'm trying to articulate, about the action that we're taking within the system to try and address the problem of excessive weights. That is the fundamental issue. As important as the Assembly debate is, it's shining a spotlight on an issue.
It's not that important. You didn't know any detail.
It's shining a spotlight on an issue that we're working rapidly to try and address, and that's the point that I'm talking about today.
Okay, Rosie's next.
Thanks, Richard, for coming to the committee today. I'm also very frustrated just at the lack of information and the attitude. I mean, on one hand, you're saying it's not perfect, but do you think then it's good? What does that mean?
Well, it means it's not. I mean, it could be better. I mean, clearly, I don't think anyone could argue that if the choice was between having a minister full-time and having a minister for certain periods of the week, preference would clearly to have the minister full-time. But the subtlety of that question is, what is the practical implications of the minister not being there full-time? I'm just trying to articulate that the practical implications are that he is still, in the limited time he is available to the department, focusing that time on directing the strategic movement of the department towards a number of key issues. So those discussions are continuing.
Yeah, well, I mean, I suppose, like other members of this committee, it is really disappointing that the Minister can't turn up to answer questions or to respond to things. But other ministers who have resigned and went back to their job seem to be able to do that. So it's as though health isn't an important enough issue, but other issues are. That's hugely disappointing. Also, the Chair referred to the guidance from the Commissioner for Older People, and that's been available for nearly a year, and you don't know anything about that. And we're going to be speaking this afternoon to the Commissioner, and what I would like to know is, have you had discussions with the Minister? Has he raised it with you? I mean, it's not on your table, obviously, because you said there's nothing pressing on the desk, so it's not even on the desk. Have you had discussions with the Minister?
It's an issue that has been discussed with the Minister. It's clearly an issue that the Department is alive to, and you know, the fact that without any advance warning the question being thrown at me, I can't provide an answer to it, shouldn't dilute the fact that, or hide the fact that many colleagues in the Department are working proactively in this and taking it forward. And that's a picture that I will convey to the committee after this session. We'll provide more information.
I just find it amazing that this is such a big issue. It's never far from the headlines about residential homes, care for the elderly, how old people are treated, abuses and neglect, and you can't think of anything that the Minister might do.
Well, with respect, that's not what I'm saying. What I'm saying is there's a specific question about the Department's position on a report that covers, as you've indicated in your question, a wide range of areas. And I think to give proper service to the committee, the response to that should be as comprehensive and as wide and cover all of those areas, and that's what we will provide for the committee. I think the committee deserves that, not some half-hearted attempt, as I say, coming here, not anticipating a question that. And Chair, I think the lesson for us is that we need better notice about the issue, because I genuinely want to work with the committee and provide information, and I hope that no committee member takes anything other than that. But the reality is, if we're going to properly cover issues in the level of detail that the committee wants and deserves, I think we need some prior.
I don't know, with respect, Richard, how you can say we need better notice. You're in charge of the system. You should know what the key issues are and where their current status.
But Chair, I think the better notice point is accepted on both sides. I mean, I can recall it wasn't too long ago that you actually wouldn't let some of my colleagues in the room to discuss the paper because you felt you hadn't received the paper in sufficient time. But I think it's fair that plays both ways.
But, I'll make the point again, Richard, that the formal guidance, it was formal guidance to the Department. Formal guidance,
Chair,
which there are sectors across society know that document inside out, with 4 recommendations.
I take that point, Chair, but I would say we're not a department that is short of formal guidance on a range of very, very important and strategic issues for Northern Ireland.
Okay, sorry for interrupting, Rosie.
Okay. You said, Richard, earlier that I mean, you're nearly making the case that you don't probably need a full-time minister because so much goes on.
I wasn't making that
well,
case.
It sounded a wee bit like it, but however, what you said was there are just some decisions that are required for the minister, but generally you can take decisions and keep things moving. Can you tell me why then we have been having our questions rejected by the department? Surely, those are questions that could be pursued by the department.
Well, as I understand it, on the issue of assembly question, I mean that's an issue for the assembly authorities to handle. My understanding is that the assembly has decided not to accept questions.
So if we write to the department, then we will be able to have those issues pursued.
We are continuing to respond to any correspondence we received, either from the public or for elected representatives. The issue being, if the question is asking about factual information or an established position, we will answer that. If the question is asking for, where might the minister go on an issue, that issue will just be held until the return of a minister. But questions that we are able to answer, if they come in terms of correspondence, I've received myself a number of emails from elected representatives which we continue to process and answer.
So if there's an urgent question and we could be without a minister for who knows how long, that will not be resolved or not be dealt with because there is no minister. So if it requires a minister, it doesn't matter how urgent it is, it's not going to go anywhere.
But again, sorry, do you mean like an urgent assembly question or just a general issue that's of that has an urgency?
Well, if it's something that requires an urgent answer, I mean,
Well, but if
anything
there
can come up.
any questions that come through to the department that we are able to answer, be they a request for factual information or an articulation of a current policy position, we will process those and answer them, and we'll endeavour to meet any timetable that the questioner puts regarding the urgency. The only issues we can't answer, for instance, a question asking us to speculate on where we might land in response to Donaldson or the review of commissioning, they're issues for the Minister and couldn't be answered. But, for example, a question asking about the number of people waiting for certain procedures at a point in time, we will provide that information very rapidly.
Well, that'd be useful, I suppose, because that's not the way it was being presented. It was like it was a brick wall. So that's helpful. Can I ask you about the development of the children's services, heart services in Belfast? Can you tell me where that is currently?
Well, the work is ongoing in terms of, is this the PCCS, the work in Dublin are you talking about, or the extension of the facilities in Belfast?
Extension for facilities in Belfast.
Well, I mean, there's a huge amount of detail and colleagues are continuing to explore that. They're working with clinical colleagues. There's a governance position in place to try and roll that out. I mean, I can come back to you with a very comprehensive response, but, again, not a question I could reasonably have anticipated today.
No timeline for that, or
we can come back to you with information on that.
Well, it'd be useful.
Yeah, absolutely,
if you could
of course.
respond
Is there a
to me on
business
that.
case currently for investment in Clark Clinic
There's one in progress at the moment.
in progress? Is there a timeline, or is this delay or is this non-minister position impacting?
No, it's just a question of work and effort, Chair. It's not being held up by the Minister.
Is there a timeline then? Are you working towards a timeline when this business case will be approved?
Well, I think we're working to get it done as quickly as possible. Again, off the top of my head, I'm not sure what the exact date for that is.
I mean, is it months, or
We'll come back to you with that, Chair.
is it still the reality, whilst there has been work on the network itself,
Yes.
that there's still hundreds of children going to England for surgery?
Yeah, and that's the issue we're looking at, Chair, how best to serve those children.
But you can't give me a time.
I mean, Chair, we can rehearse this, every specific piece of information. I will come back to you with the information on it, but I'm not sure it's unreasonable for me not to carry every date in my head. I can keep repeating that, but...
Okay.
Just one
Yes,
final
Rosie,
question,
sorry.
Chair. You probably know that there's some of us in this committee are also involved in the Ad Hoc Mental Capacity Bill Committee, and it's a very, very heavy piece of work, and there's a huge volume to it, and there are issues which are starting to arise, and we are seeking clarification from the department. Now, the response we've had from the Health Department is that they can't give ministerial assurances on all of that. Now, we heard earlier that there are two health bills, and you sounded fairly optimistic that those would be possible to progress within the required timelines. Now, here we have another bill which could potentially be held up because of lack of clarity and direction from the department. So the further we go down the road, the likelihood of being able to have these bills complete their passage within the mandate look less unlikely as time goes on. Can you respond to that?
Well, the two issues we talked about earlier aside, the mental capacity bill, there are issues that require ministerial attention on that, and not just with our minister, but also our colleagues in, DOJ.
They've been able to provide the responses.
And there are issues too, I think, with the legal construction of some of the clauses. So that's a complex piece of work that requires further. But
what we're saying is the lack of a minister means that this hugely important bill could fall because there's no minister.
I think there are many challenges with that piece of legislation about the technicalities of it. But
That's it.
I accept. But some of them out with areas that require ministerial consideration. There's a whole range. But I take your point that it clearly is at the at-risk category.
It's a hugely complex piece of work, but it's people are working hard at it, and then we've got a minister who's just not at his desk. It just is it's unreal that this work is all going to be invested and it's going to potentially fall by the wayside. It's just not right that it would happen.
Thank you. And George?
Thank you, Chair. Just one question to Richard. As well as the present position that we're in at the minute, do we need to take a longer term look at how we want our elective care to be carried out to get the best value for money and performance.
I think that's one of the clearest issues that's flowing from the current position with waiting times. And we commissioned a piece of work from the Health and Social Care Board to look at a medium to long-term strategy for the provision of elective care. I mean, setting aside the issues about funding, the way we provide elective care, and I think it's impossible to separate the provision of elective care separately from the issues about commissioning and about the response to Donaldson. And if we talk about the Belfast, the 14-day cancer target, to me that's a clear issue that where we seek to replicate services in every part of Northern Ireland, each of those services is by extension smaller in size than it would be with a regional approach. And therefore it becomes inherently volatile, particularly where key staff, for instance, fall ill or take periods of leave. So and I'm not suggesting where in the spectrum, but at one end of the spectrum there are many small facilities, and at the other end there is one facility for Northern Ireland. It's where about, and that's a key issue in terms of management of elective care. There are issues about how we forecast demand, what way we plan capacity, big issue about to what extent we use the independent sector in the future. I think there are quite different issues in terms of management of the existing problem. At the moment, were additional funds to become available, I think we would have little choice but to use the independent sector in some way to help with the current problem. But just to be clear, that's a completely separate issue from the longer term issue. We could plan not to use the independent sector or to make greater use. That's not a debate we've had yet. So that piece of strategy work is needed, and I think we need to reshape how we deliver elective care across the province.
Yeah. Just a comment, Chair. I was in Elton Galvin on Friday past with my wife, and I want to commend particularly the gynae ward. The excellent treatment that the wife received is just unbelievable. The hospital itself is around quite a lot of the wards and visiting people and so forth, and all the staff up there, doctors, nurses, everybody, in my opinion, are to be thoroughly commended for the excellent work that they do. And we can't wait until the new cancer centre is built. That's nearly in operation. Yeah. That will be a terrific addition to the northwest of the province.
I mean, they're very kind comments. I'll certainly pass them on. But I know that the staff up there, and there is a tangible buzz of excitement about the new radiotherapy unit.
I know the health service gets knocked for quite a bit, and I just want to add my comment about the experiences that I have received.
And it's very well, and I think it's one of the issues that has surprised me about our system. And at any point in time, if we're ever asked about the number of complaints, we can provide a quick, accurate answer. If we ask how many compliments the service has received, it's one of the issues I've been pursuing, because I think about staff morale. I mean, we have a huge number of highly committed, highly professional staff.
Exactly.
It's actually surprising just how many compliments are received. I think maybe we need to do a bit more, certainly to make the staff that have given rise to the compliment aware that people are grateful and still see the service they provide.
The work that staff do is absolutely unbelievable as far as I'm concerned. Brilliant job. In every one of them.
Well, I'll certainly pass that on.
And the 2 million that we're losing every week, I'm sure that could be used to would be helpful. To better benefit. I know you don't want to comment from a political point of view, but at the same time, I myself know exactly what's happening. I think it's absolutely disgraceful. The money and a lot of that could be used for waiting list as well. Just wanted to make that comment.
Okay, thank you.
Just on the elective care issue then, we took evidence from England, Scotland, Portugal, Italy, and made 5 or 6 recommendations to the department around waiting times. Are you progressing those?
Well,
Can you?
I think the issue at the time that the then Minister concluded, and I think the key issue is the refer to treat target, that in concept would be supportive of a move towards that, as they've done across the water. But the reality was that where they've done it across the water, the movement to it was accompanied by additional investment. I think the view at the moment is we need to fix our performance as opposed to just putting in place a new set of targets.
Well, there was more than referral to treatment. There was issues around links of the independent sector and private sector as well. Are those recommendations being progressed?
But they'll be absorbed within, we talked about the review of elective care. I mean, that was part of the response to it. We want to actually look at the way, because a key plank of the review of elective care is how we engage on a regular basis with the independent
So those
sector.
recommendations aren't being taken forward?
Well, they've been considered by the department. I mean, I think we need to do further analysis. We need to develop a strategy to deal with the elective care problem and challenges we face. And the committee's work on that, I think, is very helpful in framing the strategic piece of work we want to do in developing a new model for elective care. And I think the RTT issue is part of that use of the independent sector. These are fundamentally important issues, but if we were just to jump to implement in full, I think the Minister...
Yeah, but has it been progressed?
The review of elective, as I said, has been commissioned. The board are working on it as we speak. The issue about the specific recommendations was the Minister took the view that at the time couldn't satisfactorily implement the recommendations without additional resources. So I think he was grateful for receipt of them. There's something that we'll factor into further work, but for cost implications they can't, and that's particularly true of the RTT issue.
Okay, Georgie, finished there, yeah?
Yes, thanks.
Pam?
Thank you, Chair. And I think just before I ask my questions to Richard, I should say that I, as a committee member, have always supported when we as a committee have decided that we haven't received the proper briefing or the information in sufficient time for us to actually deal with whatever's on the table. And I think that courtesy should be given back to the officials as well. And I certainly know that I wasn't given very much information on what this meeting was about either, quite frankly. So health is a big issue, and I'm sure I don't need to defend an official that comes before this committee, but I just feel that it's common courtesy actually to, if you want detailed answers to questions, that you should give some form of detail of what is going to be asked. But that's just a point. Richard, as far as the public's concerned, as far as our constituents are concerned, the main issue, the main complaint, the main gripe amongst my constituents, amongst my family members, amongst immediate members of my family, using a health service is about waiting times, no doubt. I don't get complaints about the treatment that is received when they get it. It's the time they wait to get that stage and deterioration in their health whilst they're waiting. So it is of vital importance that these waiting times are reduced. We know this. I've personal experience. I'm waiting on the waiting list myself for some attention from the health service, and happy to do so, as everybody else has to within Northern Ireland. I have to say, my recent experience, just as George has had recently with the health service in different departments, has been amazing. The experience and the treatment and how that treatment was brought to us as a family was second to none once you get it. Yeah. So my gripe is the waiting list, the wait to get there. And I know we talk about the use of independent providers as well a lot on this committee. But what I wanted to ask you was, is there opposition within the department to the use of independent providers? And if money was made available to bring these waiting lists down quickly, efficiently, could that be done?
Yeah. I think there's no opposition within the department to the use of the independent sector at all. Neither is there any dogma that it's the best way to address it. The reality is, if we received additional money tomorrow, it will be a combination of increasing internal capacity through trying to open theatres at the weekend and bring staff in, particularly in the area of orthopaedic and hips and knees, things like that, and giving some money towards the independent sector, to the other procedures. So it would, the easy answer to your question is, if any additional money we get, we will work out how we can get the maximum number of patient treatments for that, and be that in the independent sector or internal. We certainly don't favour one over the other. That's very much the short-term issue. I think there is a longer-term issue about, it strikes me that the model in the past has been that we try broadly to marry internal capacity to demand and leave the independent sector as a safety valve if demand increases above that which we have capacity, or if there's any issues in inability to deliver capacity. I'm not suggesting this is the way forward, but I think it's an important question going forward, that should we continue to do it that way, or maybe should we aim to deliver 90% capacity and put in place a longer term arrangement with the independent sector? I think it's worth asking ourselves, and the reason it's driven purely by value for money. One of the points the independent sector has made to me is that they don't know how much or when they will get any work from us. There's a framework contract in place which just allows us to send patients for different procedures. They have made the point to me repeatedly that if they had a contract in place for a certain period of time with a minimum number of volumes, that would allow them to make some investment in their service and be able to deliver the service to us at a much lower cost. I think that's worth exploring. From my perspective, it doesn't breach the principle of a National Health Service, because I would look at that issue from the perspective of a patient, and as a patient you get free health care to the same quality standard, free at the point of delivery, whether we use to provide it. So I think it's an important point to look at that as part of a medium to long term strategy, but in the short term we will use any avenue open to us to accelerate treatment.
I think that's a good point you make, and I certainly have seen presentations from independent providers which were very, very impressive. How they operate, because they truly operate as a business, and I suppose as a criticism we could gear towards our own National Health Service. Why can we not actually be a bit more like the independent sector and actually try to operate as a business, as if we were making a profit? We're not looking to make a profit, but as if we were to maximise the value.
The one caveat, if I may, or my clinical colleagues would never forgive me, that it's important, I think, to recognise too that it can be very, very difficult to make comparisons between the independent sector and trust performance. I think some comparisons, I think it was recently one of the broadcasters was saying that typically in an independent sector setting, a consultant in a session could get through 6 or 7 procedures, whereas in a trust facility that may be 4 or 5. The point the clinician, and it's very much a clinical point, so I pass it on, is that the reality is the more simple and straightforward procedures tend to go to the independent sector, because where there's a more complex or difficult, it stays within the trust, so that you have a backup of all the other services available within the trust environment. And there's also the fact that in the trust environment, in an orthopaedic setting, for example, a session can suddenly have to be halted because of an emergency trauma that comes in. So it's difficult to make comparisons. I think we should make comparisons, but we need to be intelligent about making them on a proper basis.
I think that's right. And just again, from my constituents' point of view, I don't think any of them care where they get their treatment, as long as they get good treatment and as quickly as humanly possible. Thank you.
Can I just confirm then, did you indicate that the board were conducting a review of independent care?
No, sorry. The point I've made earlier, Chair, we've commissioned the board to produce for us a medium to long term strategy for addressing the problem of elective care.
Okay.
As part of that piece of work, we want them to consider what is the optimum use of the independent sector in supporting our work on elective care.
So that's part of that piece of work. And is there a timeline on that piece of work?
We've asked them for a first, they've just given us at this stage an outline, it's like a skeleton outline of the areas they'll be looking at. So they've now started to work on that. I think we'll be looking for a progress report in the next couple of months from them. They're getting on with that.
Okay, thank you for that.
Chair, sorry, just for clarity, could I just ask one more small question? Do you believe if the money was made available, the Minister would be minded to put it towards reducing the waiting lists?
I don't really want to speak for the Minister, but I think it's fair to say, certainly from what the Minister said publicly, that at the moment he sees addressing the waiting challenge as being the #1 priority for him. So without wanting to commit the Minister, which I can't do, it would be my expectation that the key focus of any additional money we receive would be on addressing those things.
Okay.
Okay, thank you, Pam. And 2 members left, Fergal.
Thanks very much. Thanks very much, Chair. Can I just address the issue around praise? The Minister being in the Chamber on Monday and Tuesday, he would have heard praise from the members about both professionals in the autism sector and those involved in cancer service. Indeed, I think all of us make those points in all of the debates, so I don't think you have to look much further than the Assembly Chamber itself
I take that
in
point.
terms of praise
And
that exists.
I know
for
you,
health service.
Mr McKinney, in the past, you've been very
make that
complimentary
point
about some of the service.
and I make it again today at this committee. It's a point that I continually reinforce. Would you accept that we're in a highly unusual set of circumstances present?
Well, absolutely.
I'm interested in your responses because I really want to know who you're representing here today.
I'm representing the department.
So then the people
The institutions, the structures, the people.
would serve the public. And I just noticed that any criticism you have of the absence of a minister in those highly unusual set of circumstances is very constrained. Why is that?
Any what?
Any criticism of the
It's
situation?
not ever my role or the role of any civil servant to criticise ministers. I mean, it's not part of our responsibilities to offer any
But it
sort
is
of
your
critique.
role to question the circumstances you find yourself in.
No, it's not. It's my role to get on with the job in whatever circumstances I find myself.
And are you constrained in getting on with your job in the absence of a minister?
Well, I think we've addressed that point, that, as I said, it's not perfect, but we're getting on to the very best of our abilities.
I found the intervention from Nigel Edwards a very valuable one. Did you read the report?
I saw the comments from Nigel Edwards, yeah, and I think points of it were helpfully stating a position that didn't come as a surprise to anyone. I thought possibly part of his comments were made without a full and proper understanding of the issue in Northern Ireland. I mean, his point was that he seemed to conclude that any issue about excess waiting times was absolutely a performance issue, hence his comment, heads should roll. I think were it absolutely a performance issue, that would be a valid comment. But the analysis that we've done, the single biggest contributory factor is the lack of availability of finance. I think that's not an issue that individual chief executives can be held accountable for.
Yeah, but he may have said heads would roll, but he didn't say which heads. And you're making an assumption about which heads as a result of your comments just now. But do you recognise what he said, that these figures represent a very worrying situation for here? Do you accept that?
Oh, of course they're worrying, yes.
And that they compare very badly in England?
Well, at face value, but I think if you drill beneath the detail in terms of the level of funding in England in particular, which is a key component, I think comparisons are valid, are at their most valid when they're like for like. And I don't think we always have a like-for-like comparison. Certainly, for any of our trusts, I pretty much guarantee I could find a comparator somewhere in England that we're outperforming them. I don't think that would be a valid comparison. So I think we need to tread carefully.
Do you accept that his contention that the Northern Ireland waiting list situation requires immediate action?
Absolutely.
And does the absence of a minister in any way frustrate that immediate action?
From my perspective, as I think I've sought to articulate today, the single most important factor for us in terms of immediate action would be to secure additional resources.
If a minister isn't in his position to argue for that resource, is that frustrating that ambition?
I can't argue that it isn't relevant, but equally, when a minister was in place and made a bid to June monitoring, and we need to recognise the broader financial position. I mean, I won't sit here and argue that it wouldn't be helpful to have a minister to argue that case. Of course it would. And to get the additional funding. But it is about funding.
The minister not in his post is not helpful for the patients and public
in terms of securing additional resources, it certainly.
But additional resources is the key in your argument.
Additional resources is the key, yes.
And the minister's not there to argue for them.
Well, that's a statement of fact. The minister, as we speak, is there to argue.
Well, in the wider point, he's only there a couple of hours a week, but he's not there to argue for them, and that's frustrating your ambition.
Well,
That's your ambition.
I'm hesitating, Mr McKinney, because I'm not going to be drawn into the business of criticising what ministers do or don't do. What I would say
No,
is...
I'm not asking you to criticise. I'm asking you against your measurement. To tell me, is your job, on behalf of the people in Northern Ireland and dealing with these waiting list times, being frustrated by the absence of the Minister? It's a yes or no question.
Well, my response would be my job and the job of all my colleagues across the health service would be easier had we access to more resources.
Right, I'll go over it again.
I heard the question. That's my response to
the Minister, if he was in his chair, could be able to argue for those resources more effectively.
Well, that's yours. It is not my role to offer a critique on what ministers should do or don't.
No, sorry, let's just...
And I'm not going to be drawn in.
I'm not asking you to critique the Minister or criticise the Minister. I'm asking you, in your job as the Permanent Secretary in the Department, whose job it is, and you were brought in to do this job, is to deal with these issues. Now, is your job being frustrated or not frustrated by the absence of a Minister?
My job would be easier had I more resources. As is the case for all my colleagues across the health service.
So the job that the Minister should be doing is arguing for those resources?
Well, it's for others to talk about the job the Minister should be doing.
What's the one thing you'd be asking the Minister to do?
It is not anywhere in my job description.
What's the one thing?
Offer a critique about what ministers should do. I operate absolutely at the direction of ministers. Yeah. I do not offer
What's the
comments.
one job the Minister should be doing on your behalf?
It is not for me to tell any minister what he or she should be doing.
You're avoiding the question, not just avoiding...
I don't think it is an appropriate question for a civil servant to offer a view on what ministers should do or should not do.
Sorry, I disagree. I think it's entirely appropriate. I'm not asking you for the detail of a report. I'm not asking you for something that wouldn't have been brought to this table in any event, even in a short notice. I'm asking you, as head of the civil service, or the head of the department, in the absence of a minister, how much the absence of that minister is affecting your ability to get your hands on the money that you need to do the job.
And my role before the committee is to represent the minister and help articulate his policy agenda. I have a minister in post. It is not my job ever to offer a critique on what a minister should be doing that he or she is not doing, or the validity of what... that is just not simply a role for any civil servant. And I think any civil servant who sought to offer a view on ministerial action is treading in very dangerous territory. Can I just remind you what
you said on 22nd of October 2014, when you told this committee that the challenge the Minister faces is trying to bring all the individual strands together with a very difficult funding envelope and making those difficult choices. So you gave him advice then. Now, is that position consistent with his absence today?
What I said then, I was outlining the challenges the Minister faces. I wasn't offering a view on the actions of the Minister.
You also said we've been speaking to clinicians and other health service staff on the front line. There are passionate ideas and enthusiasm out there. So it's about grabbing the ideas, moving forward and continuing on that trajectory. Is the Minister's absence today consistent with that position?
The passion and drive of clinicians and other colleagues across the service is there. I've spent some time out in the service last week, and it's tangible when you're out at the front line.
Yeah. You also said that you'd been doing, this was about Jim Wells, of course, you'd been doing the job a bit longer than the Minister, but at the moment, even with your longevity in the post, you were still engaged in trying to understand what is a massively complex system. Is Mr Hamilton's absence from his post consistent with your view on that?
On the complexity of the system?
Yes, being there to do the job, in other words.
The complexity of the system is not a function of a minister. It's a function of the structure of the system, the colleagues in the system, the relationships across that. So that hasn't changed. Yeah.
Can I now turn to the issue of questions and information sharing between the department and the public and the Assembly, the issue that Rosie McCorley helpfully brought forward. You're aware of the Ministerial Code?
I'm aware it exists, but Are
you not aware of the detail again?
Well, the Ministerial Code is not an issue for a civil servant. The Ministerial Code is an Assembly document. Ministers are accountable to the Assembly, not to civil servants.
Yeah, but you're in the department, and the Ministerial Code in relation to information sharing 153 says that ensure that all reasonable requests for information from the Assembly, users of services and individual citizens are complied with, and that departments and their staff conduct their dealings with the public in an open and responsible way. Now, your earlier evidence suggested that in fact you're not responding in a complete way with the public, and I'm certainly not getting answers from the Assembly question system. Is that a breach of the Ministerial Code in your view?
Well, firstly, the issue of Assembly questions, they are Assembly questions. They go through the institutions of the Assembly. When the Assembly issues questions to the Department, they become a departmental issue. As I understand at the moment, the Assembly authorities are not accepting questions where there are ministerial absenteeism. I think that's an issue for the Assembly. As I think I sought to make very clear, we continue to respond proactively to any and all correspondence we receive from the public, from patients, from elected representatives, up to the point where it asks for a ministerial opinion, which we cannot give. So we continue to provide that. In terms of the Ministerial Code, that is not an issue for the civil service, that is an issue for the Assembly authorities. So I offer no views whatsoever on the Ministerial Code.
Just one final point on that. Evidentially, though, what's the size of the mailbag that's not getting answered?
Very, very limited, because the vast majority of questions we get throughout any point in a cycle are about factual pieces of information as opposed to ministerial views. So okay. Very light.
One of the big issues for me, and you will have heard this over the last number of years, is around wastage in the system, particularly the bank and agency system, because we do need to, and it refers to the discussions earlier around workforce planning, specifically on nurses. Where are we on that?
There, as part of the review of administration structures, I've asked BSO to look at the possibility. I mean, there's two strands to it. In terms of properly managing the use of agency and bank staff, at the moment that's done essentially on a trust-by-trust basis. We're looking at a way that we can better centralise that to provide a one-stop facility for the whole service, which we think will offer. The broader point is the ongoing work on workforce planning issues and the amount of money we invest year between Queen's and UJ in terms of training additional nurses, because obviously we are only ever in the space of using agency or bank nurses where there is a vacancy. Quite often those vacancies arise through issues like staff illness, but you know, there are issues.
Do you accept that it's grown now, bloated beyond its...
It's grown to a point where I'm deeply uncomfortable.
Is it grown to the point that it's actually corrupted the system in many ways?
I don't...
And that it's become a bit like you were saying with the elective care stuff. But is it grown to a point where corrupting might be too hard, but that it's actually become more attractive to bank at much increased cost to us than it is in terms of delivery?
I don't know whether we've crossed that line, but certainly I acknowledge it as a real risk that we need to address. Part of the issue are we cannot dictate to individuals that they must take up paid employment with us, as opposed to we have the same issues with the medical staff in terms of locums. I think what we need to do is continue that workforce planning and endeavour to get... part of the issue that certainly has been made to me is that some colleagues, the bank position is a bit more attractive because you come in and come out of situations as opposed to be in one place where you feel under pressure. So we need to address that. We need to support colleagues properly to deliver the high service.
That's attractive for those that are using the bank, whereas I'm concerned with those who are getting the service.
Absolutely.
Yeah. Thank you, Chair. Thank you.
Okay. Michael?
Okay, Chair. Thank you. Could I just, Richard, as far as the questions are concerned, because that's a key element of accountability as far as the Assembly is concerned. And I know when I was in post, I answered, I think, something like 11,000 Assembly questions. You're saying the blockage, or you don't get the questions, the Assembly is not accepting it. If the Assembly was accepting them, they would go down to you in the normal manner then, isn't that right?
If the Assembly accepted them, yeah.
Okay. Who would sign them then when they reach the Department if the Minister's not there?
I would need to explore that, because I think it's an issue we would need to put to the Assembly authorities, because normally the response to any question needs to be signed off at ministerial level before it can go back to an elected representative. So in the absence of someone to sign off on that, I think that's fundamentally an issue for the Assembly authorities. You know, would they be prepared to accept alternative sign-off on that?
Yeah, so in fact, if the reason why the Assembly authorities are holding the questions here, not sending them down, is because the minister is not available to sign them. What authority have you got to sign them?
I can't sign assembly questions because they need the signature of the minister, but in terms of all other correspondence, we are answering. The subtlety is where it's factual information or articulating a ministerial position that's already been made clear, we will answer that. If it's asking us to speculate about the future direction of travel or a policy agenda, we can't answer that, but that means that the vast majority of questions we are able to answer.
Effectively, then, there is that accountability question on the minister's absence, is having an important effect there. And I'm not asking you to comment on that. As far as the situation, what I'm interested in is the here and now. And we have this, I think it's a terrible situation. And I have to say, when I was a minister, if I was presiding over this, there'd be mass hysteria. I mean, George would be dancing on the table in reaction, instead of being so sanguine. Because I remember your performance in the Assembly, George.
I was doing my job.
I don't think, well, that's a matter of question. I don't get into any arguments about what you see as being your job. Yes. And you'll have issues to deal with, I know. But without getting into that situation, it's the here and now. You've heard about the cancer waiting times, and you'll be very familiar with those. I know you get the high level information and you drill down, and you maybe don't feel capable of answering in detail here. And I understand that, but you do know the situation. You're aware of where we are with cancer, with neurology, with ophthalmology, orthopedics, and so on. So you have this major issue. You have hundreds of thousands, a couple of 100,000 people waiting for appointments and so on. So there's the problem. And the question is, what are we going to do about it? And you're talking about operational issues, working rapidly to address these operational issues. So it's a clear plan of action. It is constrained by the resource available, but you will have a plan of action, I presume. And that's what I want to hear about from you. What will you do about it? What do you tell about it? Say the money situations began to ease. What would this plan of action start to look like? Well, how would you deal with meeting firstly demand, and then the key element, of course, is backlog? And what's that going to cost?
In terms of the plan of action at the moment is twofold. I'll not labour this because I think we've covered it. The medium to long term piece on the elective strategy. In terms of the short term piece, what we're doing at the moment, and a lot of it in many ways is more a clinical response than an administrative response, because and I think as what one of the members alluded to earlier, it's not a pleasant place to be on a waiting list when you have a condition that needs treatment. There's an issue about the way that is managed clinically, and the position that's in place at the moment, that essentially there are two types of referral. There's an urgent referral and a routine referral. The urgent referral is subject to a triage at the point of referral. Urgent referrals are taken then in order of clinical priority. Routine referrals are taken in chronological order. So that's the way we try the flow that is happening. And as I said earlier, there continues to be flow. We spend about £28 million a week on elective or on acute care throughout the course of the year. So that continues. We also look to the clinical community to constantly reassess and reevaluate. We make it clear to patients on waiting lists that if they feel their condition has changed or deteriorated, if they haven't made it through the first stage of the process, they can go back to their GP, who might want to uplift the category and move them from a routine to an urgent. So that's the way we manage that large cohort of patients that are on the list. Separately, the Commissioners, the Health and Social Care Board, are doing a detailed piece of work with the trusts in terms of ensuring that they deliver in core capacity. There have been some issues about capacity. The two main issues where trusts have struggled to deliver core capacity have been through staff, shortages of key staff, and the implications of the growth in unscheduled care, which clearly has implications for elective procedures. So try to get the handle and get the unscheduled care piece into a good place, and there's been a lot of good work done there through the task force led by Chief Medical Officer and Chief Nursing Officer. That's now transferred to the board and the PHA. will take the strain of trying to work with colleagues, and many trusts are in recruitment exercises to try and fill key posts. That's going to uplift our internal capacity. And beside that, it's then about waiting and hoping that we get additional funding that we can both boost internal capacity through use of overtime and additional later time, and deploy some of the independent sector activity to help us.
It's just it's to get some idea of the money, and you must have an idea very much ideally to do this. A, to get capacity up so that you're hitting demand, and then B, to start dealing with the backlogs. It's always about, and if you're not hitting demand, these backlogs are it's building and building and building. And I have some knowledge of this because I've been there. And the situation I inherited from the direct rule minister prior, whilst it was improving at that stage, was far from where we wanted to be, and we worked hard and we got it there. So I know roughly what you need to do, and it's a big task. Your waiting lists are now the worst they've been, I think, in 15 years, and it's a resource issue, and it's a capacity issue. And it's about getting that capacity up. It's the nature of the action plan.
Yeah.
I mean, we can all talk about this and go round the houses and so on, but you have an emergency situation. You have very large numbers of patients sitting in pain and distress. Some of them are coming to harm, no doubt about that. Patients will be in very severe situations. So we need to do this as an emergency situation, and you're the one then would have to pull the plan together with the board and the trusts to deal with this. Now, it's some notion of what the shape of that plan looks like. How long is it going to roll out? What are the extra resources you need? Your, I don't know what your in-year pressures are per annum that you estimate that you'll have in-year pressures anyhow. But what's the shape? What's that plan looking like? How much is it costing? What's the argument, or what's the case you'll be taking to finance and to the executive?
If I separate, as you have done, the in-year issue from the forward position, in terms of the in-year issue, as you will recall, at this point in the year, the issue is more how much would you be able to spend, as opposed to how much do you need to spend. Our estimate is that we could absorb additional funding in the region of about £1.25–1.5 million a week if we were to uplift activity. And we are constrained in terms of the number of colleagues we have employed by the trust can do this, and the capacity of the independent sector. So we reckon that would frame how much money we could take this year to address the problem. That wouldn't address the problem in totality. Going forward, the board has undertaken what's called a demand and capacity gap analysis. Their estimate is that there's a current gap between demand for services and our capacity to deliver, and current baseline funding of about £70 million a year. So that's the issue.
That's the extra money you would need just to hit demand.
That's what we would need in a steady state to hit demand. I think we would also still need some transitional funding, because the first thing we would want to do would be to clear the backlog.
But your underlying pressure actually, is it not around 200 million or 200 plus? The money you're getting from finance as opposed to the money that you actually would need to provide the service.
But I mean,
and I'm talking about more than waiting lists.
Yes, it's more than waiting lists. There's a whole range. Plus, importantly, there's a range of service developments that we want to do to actually improve the quality of the product and offer, as opposed to just improve access to the product and offer. So but for this specific issue, we think that the gap between capacity and demand is about 70 million, plus an injection to get the current waiting times down to an acceptable level, and that would allow us to go forward in a steady state. And,
well, have you have that action plan in place now?
Well, the spending review at national level for the 2016-17 year, as we understand it, is due to be announced by the UK government in about November. And at that stage, Barnett consequentials will apply, and colleagues in the Department of Finance will know the position. So that they've started a process now, and we're just initiating within the department the actual planning process to look at what funding will be available, demand across a whole range of areas beyond waiting times, to try and come up with the equivalent of the 200 million figure you raised. What is the nature of our proposal through finance colleagues for the 2017 financial year?
No, but you can't depend on Barnett because finance will just snaffle it.
True. They did.
Well,
So what they did for me on the Cameron money, the ring fenced. Anyhow, it's just if you have the plan, and what I would like to do is to see that plan, and you reckon the board have that demand gap analysis ready?
yes.
And I think, Chair, it would be very important that we have a look at them because they're the ones who are actually there to manage the health service. But the actual step by step is that if I had been there, the Minister takes that to the Executive and argues his case and gets all party support. And that would be the next step.
Yeah.
That would be the next step in that. So if the Minister's in place or even for whatever, have you got that ready to hand to him to take that to the Executive?
Well,
To say the Executive, look, everybody, whether the top slice, whether finance finds the money, whether we can get some more out of Barnett or whatever.
in terms of the
You
16-17.
need money. This, if you don't get money, this can't be fixed.
What?
You can't get the demand, the supply up to hit demand, nor can you begin to deal with the backlog.
In terms of 16-17, we've started work because colleagues in finance have just recently indicated to us the timetable that they'll be operating. And the first stage in that process is all departments are invited to submit their proposals. So we've now initiated a process within the department to start working up basically our ask of the Executive for 2016-17.
That's 16, but right now, if you had it, you could spend 1.25 to 1.5 a week.
Yeah.
On this.
Yes.
So that's a special emergency case to the Executive.
Yes. Yes. And we'd be ready to go with that any time.
All right, that's great. Thank you,
Thank
Chair.
you. Farragut was on
Yeah,
it,
I
yeah.
just want to come back in on this because I agree with Mr McGimpsey that it is a resource issue, but it is also a continuing failure to deal with this at a strategic level. You know, the finance package that was put in to help A&E took away from elective care, and this is a merry-go-round which I think is making us all dizzy because it's systemic failure. So where is the strategic issue which is actually dealing with the long-term demand and the investment in the primary sector that was part of TYC, which we've probably managed to collectively investigate well to the extent of it we don't know where it is.
Well, the longer-term plan, I think, and forgive me if I've misinterpreted you, Mr McKinney, you're really getting into the territory of Donaldson, the review of commissioning, how we structure and deliver health and social care in Northern Ireland. That work is very, very well advanced. I mean, the big issue with Donaldson, Sir Liam delivered his report at the end of December last year. There was a period of public consultation which ran until the end of May. There was 142 consultation responses received, I think extending to 360 pages of text. So big bit of work in terms of analysing the views in that. So we've been going through that. We've been having those discussions with the Minister.
Once a week?
On a weekly basis. We'll be having those discussions on a weekly basis throughout the period post-consultation. So we're at the stage now where we are very close to the point where we will have a clear view of where we think the system should move to for the longer term. And that encompasses both the Donaldson issues and the response to the review of commissioning, which are two very significant issues. And as I say, we're virtually at an end of that analysis piece of work on drawing our conclusions from that.
It has been delayed, of course, by the absence of the Minister.
The work that we've had to do is the work we've had to do.
A yes will do.
Well, I'm going to let...
Just say yes. Is it being delayed or is it not? You can do.
I don't feel it has been delayed, Pat, because...
You're supposed to have announced it by now.
But I think I dealt with this issue. We were surprised by the sheer volume of evidence and analysis we had to do when we get into the review of commissioning. This is a failure by of officials at the pace we have taken this for. The original timescale, I think, talked about the end of August. We were not in a position at the end of August to put a set of decisions to a minister to conclude on that. We continue to work on that. We've had those discussions. As I say, we're very, very near the end point in this in terms of the ability to reach conclusions.
Okay, Chair. Thank you.
Okay. Richard, thank you. I know we've gone slightly over time. I mean, I'm certainly not assured today that what I've heard doesn't highlight what we've been saying collectively, that there is a gap, and there's a gap particularly at that strategic leadership and decision-making role, which is impacting across the delivery of our health service and is impacting on therefore day-to-day lives. We have raised a number of issues, Richard, today. I would expect that we would get responses to those from the key pieces that are currently ongoing to the piece around the action plan and delivery. So thank you for your time today.
Chair, just one small,
Yes, Stuart, yes.
one small point from my own point of view. And the very fact, and I've alluded to it a couple of times, is the fact that I'm reaching £2 million per week. Michael, there's just done a few stats there, but how much money it's taken, you know, to run the service every week, and that would be a big plus for getting that back again.
The underlying,
£2
pressure's
Sorry,
over
sorry.
200,
I appreciate that,
and
but
that has
it'll be a
been
big
there
help.
since 2011.
That's right. This
Yeah, but
will
it's
be
big
built
help
up
from,
now to
from all the parties.
This well predates
Realise
welfare
that.
cuts. Let's be very clear about that. Rosie, did you want in on that?
Can I just make a point that
Yeah, big help.
if we do not deal with the issue of welfare cuts and how it will affect severely disabled people and disabled children, then those people will end up being coming to the attention of the health service and will cost the health service more, because we are all agreed that prevention is better. So I don't accept that argument. There's more to it.
Okay. Thank you, everybody. Thank you.